Good day, everyone. My name is Ebikonbowei Alexis Okaba, and I want to say a very big thank you to the organizers of this conference for the opportunity to present a paper written by me on the cholera outbreak in a rural South Nigerian community, a case control study. So this is a table of contents where we talk about the introduction that is introduced, what cholera is all about, and how it has affected Africa, Nigeria, and the community, Toru-Orua itself. The materials and method we used in collecting our samples, study area, study population, the definition of cases and control, that is how we defined our cases and control. Also, how we identify the cases and how we recruited our controls. The sample size calculation, laboratory investigations, environmental assessments, data management and analysis, ethical consideration, results, discussion, conclusion, and then reference. So let's get into its. So cholera remains a global threat to public health and a key indicator of a lack of social development in any nation. Cholera is an acute diarrheal disease caused by gram-negative bacillus bacteria called the Vibrio cholerae of the serogroup O1 and O139, which is usually associated with high morbidity and mortality. Cholera is transmitted through the fecal oral route via contaminated food, carriers, and unsanitized environmental conditions. Cholera outbreak tends to occur because of the contamination of food or water with these Vibrio cholera organisms due to poor personal hygiene, unsafe environmental conditions compounded by lack of potable water supply. The onset of cholera, the onset of cholera often starts with stomach cramps, vomiting, and diarrhea, and if left untreated, may progress to fluid losses for up to 1 liter per hour, resulting in severe dehydration, metabolic acidosis, and consequently may lead to kidney failure, shock, coma, and deaths. Globally, it has been estimated that about 3 to 5 million cholera cases occur yearly, and 28,000 to 150,000 deaths is recorded yearly as a result of this cholera. However, the infection is common to developing countries in the tropics and subtropics with high human poverty index. And cholera is endemic in Africa, parts of Asia, Middle East, and South and Central America. In Africa, there's been a recurrent cholera outbreak characterized by a large disease burden and high case fatality rates. African countries accounted for about 3,316,201 suspected cases of cholera, which was reported by the World Health Organization between the year 1970 to 2012. And in the year in the year 2012, sub-Saharan Africa reported 71% of cases and 86% of cholera deaths in only sub-Saharan Africa alone. Nigeria is reported to be one of the three major current cholera foci in the world. The first series of cholera outbreak in Nigeria were reported between 1970 to 1990. Subsequently, recurrent outbreaks followed. In 2010, Nigeria reported a total of 41,787 cases with 1,716 deaths from 18 northern states, with case fatality rate of 4.1%. This case fatality rate exceeded the mean overall case fatality rate of 2.4% reported in Africa from 2000 to 2005, and the 1% WHO acceptable rates. On the 4th of June 2024, the Nigerian Center for Disease and Control Prevention, NCDC, through the Disease Surveillance and Notification Officer, reported an increase in the number of cases of vomiting and diarrhea in Toru-Orua village, Sagbama local government area of Bayelsa State, Nigeria. The Bayelsa State Ministry of Health, Public Health Department was notified of this outbreak. And an outbreak response team was immediately mobilized and deployed to Toru-Orua village. The team investigated the outbreak with the objective of verifying the diagnosis, identifying the risk factors, and instituting appropriate control measures to control the outbreak. Now, the materials and methods. How a case control study was conducted to identify the associated risk factors of cholera outbreak. Also, a laboratory analysis of stool and water samples from the community was carried out, and appropriate control measures were instituted. The study area. The case control study was conducted in Toru-Orua community, Sagbama local government area, Bayelsa State, Nigeria. Toru-Orua community in the south-south region of Nigeria has an estimated population of about 2,000 people. The main economic activities amongst the Toru-Orua community residents are farming, petty trading, and fishing. The River Forcados serves as a major source of drinking water for most of the community residents. The Toru-Orua community also have just one primary health center. The study population. The study participants constituted of 93 recently identified cholera cases and 118 community controls identified in the Toru-Orua community. The cases and controls were recruited into the study using the following definitions. For the case definition, we defined a suspected case of cholera as any person or patient aged 5 years and above with acute watery diarrhea or with or without vomiting living in Toru-Orua community from the 14th of May to the 14th of June 2024. While the control definition, we define the control as any person living in the Toru-Orua community from 14th May 2024 to the 9th of June 2024 who did not show any sign of diarrhea between the ages of 5 years and above. So how did we identify these cases and how did we recruit our controls? We obtained a line list of all the cases, both previously and current cases, admitted at the Toru-Orua Community Primary Health Center from the Disease Surveillance and Notification Officer. A community active case search was conducted, and all cases meeting the case definition were recruited. Information on their age, sex, residence, date of onset of illness, signs and symptoms, and the outcome were obtained from the cases and used to generate the hypothesis about potential exposures that were common to the cases. In households with multiple cases, all the cases were recruited into the study. The controls were systematically recruited in the community, starting from households that reported cases. We visited the second household to the right of the case household in the selected household. All members of the households were listed, and one member selected randomly as control. Only one control was selected, even for case household with more than one case. Interviews with control groups, household members who had reported history of vomiting and diarrhea were excluded. So the sample size calculation. We used a 95% confidence interval, power of 80%, odd ratio of 4, and a case to control ratio of 1:1.5. A sample size of 44 cases and 116 controls were calculated using the EpiInfo version 7.1.3.10 StatCalc. However, 93 cases and 118 controls met the inclusion criteria and were recruited for the study. Interviewers administered structured questionnaires to the case and controls in English and the Izon languages. The questionnaire captured the social demographic information, clinical information, risk factors, knowledge and attitude and practice on cholera. Also, laboratory samples were collected, 2 samples from 4 cases, and we tested the samples using the cholera rapid diagnostic test kits. 4 case samples out of the 93 case samples were collected because not all the patients were accessible at the time, especially as it was a time of emergency and in a resource poor setting where public health infrastructure is limited. Water samples also was collected from the river Forcados, and these samples were sent to the University of Africa Toru-Orua Microbiology Laboratory Lab for isolation of vibrio cholerae using the thiosulfate citrate biosalts, sucrose agar culture media. Activities and practices in and around the source of water supply to the Toru-Orua community, that is mainly river Forcados, were noted. Using the WHO's guidelines for drinking water quality to ensure standardization, drinking water storage facilities were also inspected. How did we manage our data and the analysis? We conducted a univariate and a bivariate analysis. We characterized the data in person, place, and time. We calculated cholera incidence by age and sex. The outbreak timeline was summarized as an epidemic curve. Cases were compared with control by calculating the odd ratio with 95% confidence intervals. Ethical considerations were also put in place. Informed oral consent was obtained from the participants before the interviews because the outbreak was in a rural setting and most respondents were uneducated and unable to read and write. Confidentiality of the respondents was ensured through data coding. Due to the exigencies of the response, the Bayelsa State Ministry of Health Research Ethics Committee waived the ethics approval permission. Permission was also obtained from the Department of Public Health, Sagbama local government area. During the response and preliminary report of the outbreak was discussed. Okay, during the response period and the preliminary report, the outbreak was discussed with the Pere, that is the king of the community, the Toru-Orua community, and the Sagbama local government public health department. Now, the results. A total of 211 participants were recruited for the case control study, of which 93 were the cases and 118 the control. The mean age of case and control was 20.3 years and 25.4 years old, respectively. Females constituted 23%, 23.7% of the cases and 28.4% of controls. The proportion of those aged 30 years and above was 10.4% among cases and 17.1% among the controls. Overall, 44.5% of the study participants had secondary school education. Christianity was seen to be the most practiced religion among the participants, and farming the most predominant occupation, with 18.5% of them being farmers compared to 28.9 of the 18.5 of the cases, 18.5% of the cases being farmers compared to 28.9% of controls. So, sorry, the figure one, the tables are not showing, but with time I will upload the tables. So, but the figure one shows the epidemic curve of the outbreak. The index case was reported, that is, the first case was reported on the 20th of May, 2024, with subsequent cases being reported within 5 days of the index case with symptoms. The outbreak was peaked on the, that is, the highest day was on the 2nd of June 2024, and the last case was reported on the 9th of June 2024. The 6 cases that succumbed to deaths were reported in the 2nd week of the outbreak and occurred before the commencement of the response to the outbreak. The response was initiated on the 6th of June when the state authorities were notified, and the outbreak was controlled on the 9th of June, where no case was being reported. So there was a 3 days interval from when action was taken to curb the spread of cholera. The most frequently reported symptoms by cases were diarrhea, as 93% of the cases, 93, that is 100% of the cases reported this symptom. Vomiting was 48% of the cases reported vomiting, while 15 of the cases reported abdominal cramps, and 20 of them reported that they had fever. The least symptom experienced by the cases was headache, which was experienced by only 10 persons. The overall cholera attack rate was 4.7%, with 93 cases and 7 deaths. 7 deaths. The case fatality rate of 7.5% among 2,000 residents of the Toru-Orua community. Compared to the controls, which is 81.7%, cases 23.8. Compared to the controls, the cases were more likely to get their drinking water from the river Forcados than from any other water source available to them. Washing hands with soap or ash before eating was found to be a protective factor, as control had a 70% reduction in the risk of acquiring diseases following their hand washing practices. And compared to the controls, the cases were 6 times more likely to come from households with more than 5 persons living. That means overcrowding was also one of the risk factors that was identified in this study. All the 2 specimens tested positive for Vibrio cholerae using the rapid test kits, while the river Forcados sample yielded material growth of coliforms. The river Forcados was found to be macroscopically clean with high current flow. But the growth of coliforms in the river might have been due to mass bathing, washing of clothes, and indiscriminate defecation in and around the riverbank and inside the river. The community had only 3 non-functional boreholes at the time of this study. And it was observed that majority of the residents defecated at the bushes behind their houses, while 3% of them used shallow pits latrine. Waste management was found to be poor, with refuse heaps littered around the houses, which is a very this thing for the bacteria to thrive, a very good environment for the bacteria to thrive. So the discussion, the epidemiologic and the environmental evidence indicated that the cholera outbreak resulted from drinking water from the river Forcados. Poor personal hygiene and overcrowding were also identified as a major risk factors for acquiring the disease. These findings agree with similar studies in Nigeria. However, many cholera outbreaks in Nigeria are not epidemiologically investigated to identify the risk factors for the illness, and therefore, control measures are empiric without addressing specific risk factors associated with the outbreak. Lack of potable drinking water and insufficient awareness and treatment strategies has kept many of the rural communities at risk of cholera once introduced in their community. The cholera epidemic affected all age groups in the community, although age group 5 to 9 years had the highest proportion of cases. And our findings shows that this our study is in agreement with other studies that have been done in Nigeria, but contrary to the study done in Nepal, where less than 5 years old were mostly affected, although in our study this age group was what excluded. From the epidemic curve, it can be suggested that household contacts could be an underlying factor for community-wide transmission of this outbreak, as the main source of drinking water in the community was contaminated, and many of the community members exposed to infection. Given that only 5 to 10% of cholera cases present with classical symptoms, it's likely that nearly half of the community members were infected. Deaths occurred earlier in the outbreak before response activities were instituted. Response activities would have been more effective in preventing cases and deaths if it was instituted timely. However, timely response is dependent on the timely notification and confirmation of the outbreak, hence the need for a more sensitive community-based reporting of public health events. The long-term solution for cholera control lies in economic development through universal access to safe drinking water and adequate sanitation. Crucial cholera epidemic preventive mechanisms remains providing a waste management system that separates waste from the water supply. Oral cholera vaccines that also are additional efficient tools to control cholera outbreak are yet uncommonly used in Nigeria. These oral cholera vaccines, though not a replacement for the conventional control measures like portable safe water and personal hygiene, could serve as a complementary measure. Like in Guinea, 2 complete doses. Okay, let's just go to conclusion. An outbreak, in conclusion, we could say that an outbreak of cholera was investigated in Toru-Orua community in Sagbama local government area by Osun State. It was established that drinking water from the river Forcados was a major source of the outbreak. Poor personal hygiene and overcrowding were also identified as the risk factors. And on the interim, health education on proper hygiene and chlorination of water were initiated based on our recommendation and this controlled outbreak. The implementation of the targeted interventions such as rehabilitation of existing boreholes, construction of standard pit latrines, and the establishment of proper waste disposal systems, and developing innovative educational tools on water sanitation and hygiene to teach the children in the community are long-term long-term solutions for preventing future outbreak of cholera. So thank you for listening and God bless.